Today, we are taking a full system approach to gastroenterology. We're skipping the basics and jumping straight into the pattern recognition that really defines major GI diseases.
This is all about learning the high-yield concepts that stick.
Exactly.
Our mission today is really confidence building. I mean, if you're preparing for a meeting or just trying to quickly master a complex field, rote memorization just fails. It always does.
It does.
We need to look at the associations, the mechanisms, and the critical distinctions, the anatomical, the physiological, the cellular differences that explain why one disease presents completely differently from another.
So we're basically unlocking the entire GI tract framework for you.
That's the goal.
And we're starting immediately in the pediatric space because here, those tiny details are often the most critical clue. We're talking about vomiting in a newborn, and specifically the absolutely vital difference between a baby who is vomiting bilious material versus one who is vomiting non-bilious material.
And that simple color change gives you massive geographic information inside that baby's digestive tract.
Right.
If the vomiting is non-bilious, clear or milky, the obstruction is located before the duodenal papilla.
So in the stomach or the pylorus.
Exactly. But if the vomiting is bilious, the obstruction is located past that point, where the common bile duct empties in. So the problem is downstream.
Okay, let's unpack this with the classic non-bilious case. Hypertrophic pyloric stenosis, HPS.
HPS is such a classic story. It typically presents around 4 weeks of life, so not right at birth, often in a firstborn male.
And there's an association with macrolide antibiotics, right?
There is, like erythromycin. The pathology is this concentric hypertrophy, a thickening of the pyloric sphincter muscle, which leads to this characteristic projectile non-bilious vomiting.
Projectile.
I mean, the sphincter is so thick, everything just rockets back out.
And all that vomiting causes a very specific a very memorable metabolic state. It's not just dehydration.
No, it's a specific acid-base problem.
Oh, it's
precisely. Because the infant is losing huge amounts of hydrogen chloride stomach acid, they develop a hypochloremic metabolic alkalosis.
But the story doesn't end there.
It doesn't. The loss of volume then activates the body's renin-angiotensin-aldosterone system, RAAS, which tries to conserve volume, but in the process, it just drives potassium excretion.
So it's this vicious cycle where the volume loss triggers a hormonal cascade that makes the potassium
drop even further. That combination, hypochloremic metabolic alkalosis, is the absolute biochemical hallmark, all because they can't keep their stomach acid down.
Amazing.
And on physical exam, if you're lucky, you can actually feel it. You can feel the thickened muscle as the palpable olive-shaped mass.
Okay, now let's pivot sharply to the bilious scenario. Duodenal atresia, DA.
Right.
The shift in presentation is dramatic. It's much earlier, usually within the first 2 or 3 days of life.
Yeah, duodenal atresia results from a failure of the duodenum to recanalize during fetal development. And this is a crucial anatomical distinction. The duodenum develops from the foregut.
And since the obstruction is post-pyloric.
The vomiting includes bile, hence bilious. Imaging is absolutely key here, showing the classic double bubble sign, the stomach, and the proximal dilated duodenum.
And there's a strong, strong association with Down syndrome.
A very strong one. So when you see that double bubble and bilious vomiting right after birth, you have to be thinking DA and Down syndrome.
That's the pattern.
That's the pattern. And just to round out the obstructions, keep in mind the difference between that and jejunal atresia. That's often caused by an ischemic event in utero, not a failure of recanalization.
And that gives you a triple bubble on imaging.
A triple bubble, right. And then there's the truly urgent scenario of midgut volvulus, which is a twisting of the intestines. That is the most acute emergency.
That's the one you can't miss.
Cannot miss. If you see bilious vomiting and an upper GI series shows a corkscrew duodenum, that's immediate surgery. The twisting can cut off blood supply to the entire midgut fast.
Okay, since we've covered obstructions, let's shift to structural defects. Abdominal wall defects. Gastroschisis versus omphalocele. What's the single most important differentiating feature for the listener to remember?
It is all about the sac.
The sac.
Gastroschisis is a defect, usually to the right of the umbilical cord, and the bowel loops are exposed. They are outside the body with no covering sac.
Just out there.
Just out there. Omphalocele, however, is a defect right at the midline, and the contents are covered by a visible sac made of peritoneum and amnion.
And I understand the presence of that sac often suggests other systemic issues.
It does. Omphalocele is frequently associated with other congenital anomalies, like Down syndrome. Gastroschisis is usually an isolated defect.
Speaking of anatomy, we have to talk about neural control. specifically a really difficult diagnosis like Hirschsprung disease.
This is a failure of proper nerve development. The cause is the failed migration of neural crest cells to the distal colon and rectum.
The precursors to all the peripheral nerves.
Exactly. So this results in a segment of the colon that lacks both the Meissner plexus, which controls secretion, and the Auerbach-Myenteric plexus, which controls the muscle contractions.
So if the segment lacks the nerves for contraction and relaxation, it just becomes chronically constricted, paralyzed.
Correct. That tight, non-relaxing segment prevents the passage of stool. So the disease presents as a failure to pass meconium, a tight anal sphincter on exam, and then that classic, almost counterintuitive, explosive expulsion when you withdraw your finger.
Because the stool finally escapes.
It finally escapes that constricted zone.
Let's wrap up our pediatric section with two major causes of bleeding. First, intussusception.
Intussusception,
No.
typically seen around 1 year old. It's a telescoping of one segment of the bowel into an adjacent segment, most often at the ileocecal junction.
And the physical signs are P.
Crucial. Intermittent, severe abdominal pain. The child drawing their legs to their chest, a palpable, sausage-shaped mass, and the hallmark, current jelly stools.
That mix of mucus and blood.
Yep. And what's interesting is that an air enema is often both diagnostic and therapeutic. It just pushes the bowel segment back into place.
Now, contrasting that with the #1 cause of painless rectal bleeding in a child, Meckel diverticulum.
The painless bleeding is key. A Meckel diverticulum is a true diverticulum, meaning it involves all layers of the gut wall. It's caused by a persistent vitelline duct.
And there's that mnemonic.
The rule of twos. Present in 2% of the population, often symptomatic before age 2, and usually located within 2 feet of the ileocecal valve.
And the reason it bleeds is not the anatomy itself, but what's inside it.
Exactly. The bleeding is caused by ectopic tissue, usually misplaced gastric tissue, which secretes acid and causes ulceration. We diagnose it with a 99 millitc per technetate scan, which lights up that ectopic gastric mucosa.
Perfect. That really covers the pediatric essentials. Let's jump up now to section 2, the esophagus. Motility, injury, and the critical cancer progression pathway.
Right. When evaluating dysphagia difficulty swallowing, the first question is always, is it solids only? Or is it solids and liquids at the same time?
And that's a huge fork in the road.
It's paramount. If the patient has difficulty with both simultaneously, you should immediately be thinking about a motility issue. And the classic one is achalasia.
Achalasia, failure to relax.
That's what it means. The root cause is the loss of inhibitory neurons in the myenteric plexus. This leads to the lower esophageal sphincter, the LES, being perpetually contracted. It just fails to relax when food hits it.
Which gives you that unforgettable bird's beak appearance on a barium swallow.
The bird's beak, that narrow tapering at the LES. But we have to remember it's not always idiopathic.
Right, you have to rule out other causes.
You do. You have to rule out secondary causes like Chagas disease or even an underlying malignancy, which we call pseudoachalasia.
Now, let's differentiate that from diffuse esophageal spasm, or DES. This one tricks people because it often presents with severe angina-like chest pain.
The pain is from these highly uncoordinated, non-peristaltic contractions. And what's really interesting is that this chest pain is often relieved by nitrates, just like cardiac angina.
Because nitrates relax smooth muscle.
Exactly. And the imaging feature here is the corkscrew esophagus on barium swallow.
Let's discuss the reflux cascade, which is so central to long-term GI cancer risk. It starts with GER, decreased LES tone.
Right.
We noted in our sources that this is why pregnancy so often causes heartburn progesterone, relaxes smooth muscle everywhere, including the LES.
And that chronic persistent acid reflux is what causes the long-term risk. The esophagus, which is normally lined with protective stratified squamous epithelium, it tries to adapt to that constant acid insult.
And that adaptation is the key stepping stone.
Yes, that adaptation is Barrett esophagus. The stratified squamous lining gets replaced by intestinal non-ciliated columnar epithelium. It's an intestinal metaplasia.
And that cellular change dramatically increases the risk of which malignancy.
Esophageal adenocarcinoma. This cancer happens almost exclusively in the lower one-third of the esophagus and is overwhelmingly linked to GERD and Barrett's.
So if you're looking at cancer in the lower esophagus, think adenocarcinoma. But if the cancer is in the upper two-thirds,
it's usually squamous cell carcinoma, different risk factors, things like smoking, alcohol, and a condition called Plummer-Vinson syndrome.
That's the triad of dysphagia, iron deficiency anemia, and those esophageal webs.
That's the one.
Okay, let's hit 2 traumatic injuries, one minor, one potentially catastrophic. Mallory-Weiss versus Borhave.
Mallory-Weiss syndrome involves only mucosal and submucosal lacerations, usually after severe retching. It's painful, it can bleed, but it's not transmural.
It's not a full tear.
Right. Borhave syndrome, however, is a full transmural esophageal rupture.
That sounds like an instant surgical emergency.
It is. It happens after violent retching, presents with severe sudden chest pain, and the classic physical sign is subcutaneous emphysema crepitus in the neck from air leaking out of the rupture.
Wow.
And finally, for infectious esophagitis, particularly in immunocompromised patients, you need an EGD with biopsy. But you can often make an immediate educated guess by the visual pattern.
Let's do a quick fire round. White plaques.
Think candida, treat with fluconazole.
Small punched-out ulcers.
Herpes simplex virus, HSV, acyclovir.
And large linear or giant ulcers.
Cytomegalovirus, CMV. That requires ganciclovir.
Knowing those three visual patterns is a fantastic shortcut.
Okay.
That brings us to section 3, peptic disease, IBD, and vascular hotspots. Let's start with the classic contrast, gastric versus duodenal ulcers.
The timing of pain relative to food is the single most important clinical differentiator. It tells you everything.
Okay, let's hear the analogy.
For a gastric ulcer, think of it this way. Food is poison. The pain worsens with meals because eating stimulates acid. So the patient fears food, they lose weight.
And they have a higher risk of malignancy.
Much higher, so their margins must always be biopsied. Bleeding is usually from the left gastric artery.
And for a duodenal ulcer, food is the buffer.
Exactly. For a duodenal ulcer, food improves the pain because it transiently buffers the acid. So patients eat more, they often gain weight, and they are almost always associated with H. pylori.
And location matters there.
Location matters a lot. Posterior duodenal ulcers risk massive bleeding from the gastroduodenal artery, while anterior ulcers are more prone to perforation. That's where you see the air under the diaphragm.
Let's quickly touch on stress ulcers, Cushing versus curling.
Cushing ulcers are neurogenic. They're tied to increased intracranial pressure, which stimulates the vagus nerve and causes a surge in gastric acid.
And curling ulcers.
Seen after severe burns. They're due to widespread mucosal ischemia, just poor blood flow to the stomach lining.
Now for the great inflammatory contrast, Crohn's disease versus ulcerative colitis. This comparison really defines lower GI inflammatory pathology.
Okay, let's start with Crohn's. The key words are skip lesions. So patchy inflammation, and critically the inflammation is transmural. It affects all layers of the gut wall.
And it often spares the rectum.
Often spares the rectum, right? Endoscopically, you see that cobblestone mucosa, and because it's transmural, that leads to fistulas and strictures.
And what about ulcerative colitis? UC.
UC is inflammation that is continuous. It starts from the rectum and moves proximally. The rectum is always involved.
But the inflammation is superficial.
Only the mucosa and submucosa, that's it. And the chronic inflammation can lead to a loss of the normal anatomy, resulting in that lead pipe appearance on imaging.
And the life-threatening complication unique to UC is toxic megacolon.
Right, along with a high association with primary sclerosing cholangitis. The difference between transmural skip lesions in CD and continuous mucosal involvement in UC is the single highest yield takeaway here.
Let's close this section looking at ischemic colitis. We need to understand why some areas are more vulnerable.
It all comes down to watershed areas, regions at the borders of the major arterial territories.
So when the body's in shock.
These are the last areas to get blood. The two key watersheds are the splenic flexure, which is the boundary between the SMA and the IMA, and the rectosigmoid junction.
And we have to contrast acute versus chronic ischemia.
Right. Acute mesenteric ischemia is a surgical emergency, often from an embolism, maybe from AFib. The presentation is classic, severe abdominal pain that is radically out of proportion to the physical exam.
And chronic.
Chronic mesenteric ischemia, we call it intestinal angina. It's due to atherosclerosis, and it shows up as chronic postprandial pain about 30 minutes after eating. So you get fear of food and weight loss.
That's a fantastic distinction. Okay, on to our final section, liver toxicity, metabolism, and GI drugs.
The liver is the GI system's great filter, but it's not uniformly vulnerable. We need to focus on zone 3.
The central lobular region.
Exactly. This zone is the farthest from the incoming blood supply, making it the most vulnerable to ischemia and also where metabolic toxins are most concentrated.
Which brings us to the classic example of zone 3 necrosis, acetaminophen overdose.
A perfect example. The overdose increases production of the toxic metabolite, NAPQI, which just depletes the liver's main defense, glutathione. Once glutathione is gone, NAPQI causes that central lobular necrosis.
And the antidote, N-acetylcysteine, works by restoring that defense.
It replenishes the glutathione stores. Simple as that.
Let's quickly touch on two metabolic diseases affecting the liver: hereditary hemochromatosis and Wilson disease.
Hemochromatosis is iron overload. Iron deposits everywhere, leading to that clinical triad known as bronze diabetes, cirrhosis diabetes, and skin darkening.
And Wilson disease is about copper, which often presents with neurological or psychiatric symptoms first.
Correct. It's a mutation that impairs copper excretion. It builds up in the liver, brain, and eyes, causing liver injury, tremors, psychiatric changes, and those diagnostic golden brown Kaiser-Fleischer rings around the cornea.
Shifting to tumor overdrive, two critical GI tumor syndromes. First, the VPOMA.
The VPOMA secretes vasoactive intestinal peptide. This gives us the famous WDHA syndrome: watery diarrhea, hypokalemia, and achlorhydria, a lack of stomach acid.
And Zollinger-Ellison syndrome.
ZES.
ZES is a gastrinoma, a tumor that secretes massive amounts of gastrin, so you get hypersecretion of stomach acid. It presents with multiple recurrent ulcers that are often refractory to standard acid blockers.
They just don't respond.
They don't, and it's strongly associated with MEN1 syndrome.
Finally, let's hit three crucial drug side effects, starting with the most common. Proton pump inhibitors, like omeprazole.
PPIs.
Oh.
They work great, but reducing gastric acidity carries big risks. First, an increased risk of C. difficile infection.
Because acid is a defense.
It's a primary defense. And second, they can impair the absorption of B12, magnesium, and calcium, which increases the long-term risk of bone fractures.
What about H-Uros blockers, specifically cimetidine? Cimetidine is notorious for two unique side effects. It can have anti-androgenic effects, so gynecomastia, decreased libido, and it's also a potent inhibitor of the CYP450 system in the liver, so it can cause a lot of drug interactions.
And the motility agent, metoclopramide.
Metoclopramide works as a D-Euro antagonist. Because it blocks dopamine receptors, its main risk is causing extrapyramidal symptoms.
Involuntary movements, rigidity.
Exactly. Tremors, especially in the elderly or with long-term use.
We have covered tremendous ground, from the cellular failure in Hirschsprung to the vulnerability of the liver's central lobular zone. You really do have the full framework now to approach GI pathology, relying on those key differentiators: bilious versus non-bilious, skip lesions versus continuous, food improves versus food harms.
And as a final provocative thought that shows just how interconnected the body is, let's go back to cancer risk. We talked about how acid leads to adenocarcinoma, but consider this. If a patient is diagnosed with bacteremia or endocarditis caused by the organism Streptococcus galliticus,
Formerly S. bovis.
that's the one, a mandatory colonoscopy is required.
Wait, a bacteria causing a heart infection means we have to immediately check their colon for cancer. That feels like jumping fields.
It is a critical association. That organism's presence in the bloodstream is strongly linked to an underlying increased risk of colorectal cancer.
Ow.
Well, the theory is that the malignancy, or maybe related polyps, disrupts the mucosal barrier in the colon, allowing this specific gut bacteria to get into the circulation and then seed the heart valves. It highlights that the first sign of a GI malignancy might actually be found in the cardiology or infectious disease report.
That is a phenomenal and highly memorable piece of insight to end on. Thank you for guiding us through this essential deep dive today.
My pleasure.
We hope you feel empowered by this new knowledge. Get out